Okay, the recording started. All right. So good evening, everyone. Thank you for joining on our next session today on the road to the PSA, which is going to be on surgery and brought to us by Dr. Faisal. Um, so next session on the road to the PSA, covering sort of similar content that we've done before, but this week on surgery. Thank you all for joining. We'll get more people joining in as we go along. I'll hand over to you.
Okay, thanks. So yeah, my name's Faisal. I am a new F1. I started about 4 months ago. Just finished my first rotation in cardiology, and I had my first day today of general surgery. So maybe not as qualified as other people to talk about surgical prescribing, but passed my PSA literally like January. So, I'm not too different from you guys. I was a fifth year, this year. So hopefully if you guys have any questions about anything, if it's to do with the PowerPoint or anything to do with F1, just pop it in the chat and we'll get around to it. I think there's several topics that I've laid out, and there's questions for each. So I think what we'll do is I'll put the question up, and then if you guys can put in the chat what you think it is, and then we can get a bit of interaction going on, if that's okay. All right. So this is gonna work. Okay. So those are the topics. I've split it down into medications to do with preoperative, perioperative, and postoperative stages. And I've highlighted the important things in each one. This isn't like an exhaustive list, but it's the stuff that commonly comes up, I think, in all sections. If it's either prescribing or it's to do with, advising patients and things like that. So yeah, hopefully it'll be useful for you guys. So starting with preoperative medication. So I start with a question. So a 69-year-old man attends preoperative assessment for an elective total hip replacement. His past medical history is hypertension, AF, COPD, osteoarthritis, and depression. Medication this includes ramipril, spironolactone, prednisolone, and sertraline. And those are his observations, and he's doing okay. So, which of the following medications should be changed for the day of surgery? So there's 5 options there. So if you have a read, and I would definitely use the BNF. You're going to be using the BNF a lot. So if you pull that up alongside as we go along, get some good practice in. And when you're ready, if you put something in the chat, hopefully I can see it. I'm not sure what I'm doing. Does it go off if I move my screen? No.
No, we can still see the slides, and I've just
Okay,
popped a
cool.
message in the chat for people to react to the message when they've done. So,
Okay, cool.
yeah, when we get like a good amount of responses, you can go through it.
Cool. Yeah, they shouldn't be too bad, these questions. It is what commonly comes up a lot.
Yeah, I think we've got a decent amount of responses if you want to go through it.
Yeah. If anyone, I'm not sure if you've done it differently, if anyone wants to put the letter that they think it is. That'd be really good for me to get some audience interaction if anyone's feeling really brave. Okay, nice. Anyone else? No. Okay. Zane, well done, Zane. It is B. Let's move on. So it's emit ramipril on the day of surgery. The one that comes up the most is probably your hypertensive medications. So where on the BNF do you look for these things? A very important page for surgical prescribing is surgery on long-term medication. So I put a screenshot here. I use Medicines Complete, and I used it for all of my PSA work. I think it's really good for the PSA, but after you do the PSA, you don't really use Medicines Complete as much as just using the NICE BNF. So there's lots of positives and negatives on both. But I'd say if you want something that you want to practice what you're actually going to use as a doctor, then probably just stick to NICE. But Medicine Complete lays it a bit more, I think it lays it out a bit more nicer. It's a bit wordy, but sometimes you need it explained quite nicely. So yeah, so you can search surgery and long-term medication. I think if you even search surgery, it will come up with this page first. Um, and on this page, it details a lot of different medications, and that's where you can get information about this stuff from. I think most importantly, this is a topic that you probably should become quite familiar with and know off the top of your head. So it's quite easy to learn stuff it's easier to learn the stuff that you stop um, before an operation. So I've listed them here. Things like ACE inhibitors and ARBs, your antihypertensive, things like that, diuretics, anticoagulants and antiplatelets as well. So there are some listed there. HRT and COCP as well. They're stopped way before because they're at risk of clots and things like that, and lithium and NSAIDs as well. Um, cool. Why are hypertensives stopped? Does anyone know? What's the risk? Why do we stop them before surgery? Yeah, good. Yeah, hypertension. So that's the main issue that we're trying to prevent. So good. Nice. Um, Sometimes I'm not sure if I've actually listed them. Okay, there's some more here. The one that I used, the mnemonic that I used is I lack OP. And that lists the main ones here. So insulin, lithium, anticoagulants, COCP, potassium sparing diuretics, hypoglycemics, and then like basically, perindopril or ACE inhibitors. Here are some durations as well. Not so important. I don't think it comes up as much as just which medication you want to stop. Um, okay, and the diabetic ones. So again, it's important. It's easier just to know which ones you would change for the day of surgery, and that's just metformin if it's TDS. Excuse me. So if it's TDS, then you have a consideration. You need to stop the lunchtime dose. Sulfonylureas you emit the morning dose, and SGLT2 you emit on the day of surgery, but all the rest you continue the same. Okay. Fine. And as we said, so with most of them, it's with antihypertensives, it's useful to know the side effects. So we already said we stop them before surgery because of hypotension. Giving all of them normally, they can cause hypotension. Some important ones to know. So ACE inhibitors, they can cause electrolyte abnormalities. Does anyone know what electrolyte abnormality in specific? Yeah, brilliant. Okay. Potassium, really important one to know for the PSA. Always hyperkalemia comes up. always for a few questions as well. So hyperkalemia for sure. Hyperkalemia, you find there's a useful page called Appendix 1, if I remember, on the BNF that has a big table of all the drugs that cause hyperkalemia and other electrolyte abnormalities. So that's a good one to know about. ACE inhibitors also cause AKI and this dry cough as well. Beta blockers, hypertension again, bradycardia, and they also have it exacerbates an asthmatic wheeze as well. So you avoid it in asthmatics. Calcium channel blockers, peripheral edema. So some patients that are already at risk of peripheral edema, it can be quite bad when you give them calcium channel blockers. And things like spironolactone, again, potassium, and they can cause things like gynecomastia as well. And AKI, you stopped them in an AKI as well. So just good to know off the top of your head. It can take quite a while to find these things in the BNF, so it's good to know. Okay, cool. Moving on. So next question. Any questions about that, actually, before we move on?
We just have a
So
question in the chat
yeah, yeah. So
about if
these,
this.
yeah. Okay. So I got these tables from a very useful book called Pass the PSA. It was recommended to me when I studied. So it has these really useful tables, this one and this one, and the others I got from other revision sources. These screenshots where it says medicines, there's lots of screenshots in this PowerPoint from Medicines Complete. It will have it in the top corner here. Okay, fine. Question two. Okay, so a 65-year-old woman is due for an elective cholecystectomy tomorrow. She stopped warfarin 5 days ago, but her INR today is 1.8. So what's the most appropriate next step? So this will be in the BNF. So have a go, just chuck some words in, see what page you land on. That's how you just explore. That's the best way to explore the BNF, to be honest. It's a comment from Paul. So yeah, it's really useful to know this stuff. You'll pick it up very naturally as you do more and more questions, but this is the sort of stuff that should come naturally instead of looking everything up. You can save some time in the exam for sure. Anyone feel brave enough to put the answer in the chat? Yeah, no worries. I can't remember the timing specifically, but you do get a fair amount of time to look stuff up. Okay, so Okay, fine. B or D. So the page in particular that you want to look at. So when I see something like this, I want to maybe search things like anticoagulation, surgery, operation, and what you should get is a page called oral anticoagulants. That's a very useful page that gives you lots of advice on vitamin K, anticoagulants like warfarin and DOACs. So the answer is B. So give oral vitamin K the day of surgery. There's a very specific sentence on that page that I mentioned that says that. So as I said, you'd experiment, type some stuff in, get oral anticoagulants, control F, operative, perioperative, or surgery, or warfarin, and see where you end up. And you should get something that looks like this. And in that first paragraph under perioperative anticoagulation, it says warfarin should usually be stopped 5 days before elective surgery by mouth. Um, Vitamin K should be given the day before surgery if the INR is above or equal to 1.5. Okay. So as I said, I think Medicine's Complete talks about it a lot more better. It explains it for you. I think it's a bit harder to figure that out with the nice BNF, but I may be wrong. I haven't used that a lot. But yeah, that's where you find it on Medicine's Complete. Okay. So some key considerations when it comes to anticoagulation. So a lot of anticoagulants, they affect the kidneys a lot. So when you're prescribing, after the PSA and things like that, as well, you always need to check renal function, bleeding risk, thrombotic risk, and balance the risks and benefits when you're prescribing anticoagulation. Okay. Most patients, so a great majority of surgical patients need VT prophylaxis, so anticoagulation to prevent any VTEs from happening, either DVTs or PEs. Yeah, they're documented clearly. Usually there's a clear plan of when to stop it before surgery and when to restart it after surgery. That's quite a senior decision. But yeah, again, things that are after the PSA. Cool, fine. Moving on to perioperative medications. Okay, any questions before we move on? So we've done kind of in general, like stopping medications, antihypertensives, the side effects, diabetic ones, stopping them, and then anticoagulants. So it's all preoperatively. Any questions? No? Okay, cool. So move on to perioperative medications. Another question. A 58-year-old woman with insulin-dependent diabetes is scheduled for major abdominal surgery. She will be nil by mouth from 6 a.m. What is the most appropriate perioperative glycemic management? Okay. Anyone want to put which letter they think it is? Okay. Anyone else? Yeah. Nice, guys. Okay, so yeah, this is C. So the other ones continue her usual insulin doses. No, stop all insulin until eating. No, double dose, definitely not. And sliding scale subcutaneous, no. So again, this is something you want to search. I would search maybe something like diabetes and surgery to see what it comes up with. And there's a page called diabetes surgery and medical illness. So all these pages are quite key pages that you need to get quite familiar with, looking at the headings and things like that. So I suggest like just familiarizing yourself with them. A lot of the PSA, unfortunately, is just learning, what to search, what to type in, what to control F, what to, things like that. So with this one, there's a page, diabetes surgery and medical illness. This one, there's a section called use of insulin during surgery. Now, this question gives a lot of clues as to exactly where you need to look. So she's scheduled for a major abdominal surgery. So it's an elective surgery that's a major surgery. Fine. And she's usually treated with insulin. She's an insulin dependent diabetic. So that should lead you to look at this paragraph here. So patients usually treated with insulin who are either undergoing major procedures or whose diabetes is poorly controlled will usually require a variable rate IV insulin infusion. Okay, so usually a variable rate is started. It allows a lot more tighter control over blood sugar levels. They can be affected a lot during surgery. So we usually start a variable rate infusion. Um, Similar to that as well, when you're looking at you know, management before and during as well, it's good to know at the back of your mind on the day before surgery, their long-acting insulins, you need to give that at 80% of the usual dose. Okay. A lot of the time it's carried on as normal, but it's good practice to put it at 80%, so slightly lower than the usual. The risk of hypoglycemias during the operative period. Okay, cool. Again, a really good page just to get familiar with. It's got some information on starting potassium as well, because giving a lot of insulin can cause hypokalemia. So a lot of the time it's started with some potassium fluids as well. So this could all come up. Cool. Hopefully that makes sense. So moving swiftly on. A 54-year-old man is on prednisolone 10 milligrams a day for 6 months, and he's listed for an elective lap chole. And what's the most appropriate perioperative glucocorticoid plan? So this is to do with perioperative management of steroids. So think about your keywords, what you're going to search. So something from Paul. So presumably in the PSA exam, you can have medicines complete and BNF and BNFC open on tabs at the same time. I cannot remember if that's the case. Um, they definitely had, it was like a drop down that said either, and it could be different for you guys, but they had a drop down that said medicines complete BNF, medicines complete children's BNF, and then nice BNF and nice BNF children's. I don't know if you could open multiple ones at the same time. I can't remember exactly. But it's quite quick. If you, as soon as you have a kids question, you can close the adult one and just, it's very quick to open the children's one anyway. Yeah, anyone else finish the question? Okay. Anyone gonna back Zane? No. Zane's right. So it's D. So it's give IV hydrocortisone at induction and increase the dose perioperatively. Does anyone know why? Very simply. Yeah, good. Good. So you need to prevent an acute adrenal crisis. So yeah. So usually you give more hydrocortisone, more steroids, um, because they cortisol levels aren't good enough when you've gone through a surgery. So on the BNF, so medicines complete, I typed in adrenal insufficiency. I think you can type in surgery, steroid, surgery, adrenal as well. Have a go. But there's a section called management of adrenal insufficiency. And it says here adrenal insufficiency is treated by physiological glucocorticoid replacement with mainly hydrocortisone, as it's the most similar to cortisol. Sometimes prednisolone or rarely dexamethasone, but the widely practiced thing is to switch it to IV hydrocortisone. Hydrocortisone is only IV, so switch it to IV, and initially you give 100 milligrams, and then you give double that every 24 or so hours for the sick days. Okay, so yeah, I've labeled here so patients at risk of HPA axis suppression. So this is to prevent an adrenal crisis from happening. So usually patients that have been taking more than 5 milligrams of prednisolone for more than 4 weeks. So this patient, yeah, I put that they had 10 milligrams for 6 months. So they are steroid dependent. Okay. High dose recent steroid use, a Cushingoid appearance, so things like the buffalo hump or the moon face, that's showing long-term adrenal insufficiency. And a recent systemic steroid use through these means. Okay. So for minor surgeries, usually you continue the usual dose and you just stay on oral. You don't really do anything with it. You don't switch it to IV. You don't need to double it. But moderate to major surgery, what you need to do is, yeah, give IV hydrocortisone 100 milligrams at induction, and then you double the dose for the sick day rules. Okay, for 24 to 48 hours. Okay. Um, cool. Fine. Next thing is just again knowing roughly the side effects of steroids is really good. It comes up quite commonly in the PSA. So something I used is this mnemonic. So each letter of steroids is a side effect. So stomach ulcers, thin skin, that's with topical steroids. Edema, right and left heart failure, osteoporosis, infection, diabetes, and Cushing's syndrome. Okay, so it can come up as well. Okay. Any questions? So is this in addition to them taking the usual prednisolone dose? No, so it's stopping the prednisolone. So completely. If you stop oral prednisolone, you switch to IV hydrocortisone. Sorry if that's not as clear. No worries. Okay, cool. Okay, a prescribing one. So this is where the bulk of the marks are. So it's good to spend quite a bit of time on this section. That's the PSA. So a 72-year-old man is listed for an elective total knee replacement. His past medical history includes hypertension and osteoarthritis. No known drug allergies. The orthopedic team asks you to prescribe the appropriate perioperative antibacterial prophylaxis. So write the single most appropriate prescription that should be given preoperatively. Okay, so the drug, the route, the dose, the frequency. So how to go. Okay, nice. Someone's being extra brave. If they put the prescription, what would you prescribe this guy? Anyone want to give it a go? Okay, lovely. Yeah. Okay, so cefuroxime, good. Okay. Cool. And it's IV, nice, 1.5 grams. Frequency, so what would you for one dose? Yeah, good. So stat, this would be 30 minutes before the procedure. Okay, fine. So what I typed in is, I think I typed in antibiotic surgery, or, the specific page is antibacterials used for prophylaxis. Okay, a very specific section, so I'd control F, maybe joint or orthopedic, and it will give you a very nice section here. So orthopedic surgery, antibacterial prophylaxis. So this is a joint replacement, including the hip or the knee, like our question is. So it says a single dose of IV cefuroxime alone. And then when you click, so it says here as well, IV antibacterial prophylaxis should be given up to 30 minutes before the procedure. Okay. So if you click specifically into cefuroxime as well as an indication that is surgical prophylaxis. Okay. Initially by IV injection, 1.5 grams for one dose up to 30 minutes before the procedure. Okay. Um, it's a single prescription, so you don't need to do the ones after, you just need to do the one preoperatively. Okay. Hopefully that makes sense. So that's quite a straightforward one. That's a nice one to prescribe. Antibiotics, the other times it really comes up is to do with side effects again. So anything to do with interactions or patient advice or, the other sections it comes up quite often. It's always to do with either gentamicin, vancomycin. They cause nephrotoxicity and they also cause deafness and hearing impairment, so ototoxicity as well. And furthermore, there's a bunch of antibiotics that cause C. difficile. Okay, these are all these antibiotics that start with C. I think it's six C's or something. Usually, cephalosporin, ciprofloxacin, things like that. Okay, so just good to keep at the back of your mind again. I think, again, Appendix 1 has a lot of side effects and stuff like that, but yeah, very good to just know and save some time. Okay. Cool. Any questions before we move on to post-operative? No? Okay, cool. So we'll move swiftly on. So post-operative medications, we'll give another prescribing one a go. So this one I yoinked from the PSA, I think, one of the tests, but it's a really good one. So a 74-year-old man is admitted to hospital 7 hours after a stroke. He's been eating and drinking less than usual. Past medical history, hypertension. He just takes ramipril for that. On examination, he's okay apart from right hemiparesis, unable to swallow, and does not tolerate insertion of an NG tube. He has a cannula in. Investigation, so sodium is normal, potassium 3.9 normal, urea is slightly raised, creatinine is normal. Glucose 7.2, so chest x-ray, no cardiac failure, ECG shows no recent MI. Write a prescription for a fluid that is most appropriate for the patient at this stage. So that the prescription is, obviously it's IV. I want the fluid name, the volume, and the duration. You get quite a few fluid prescriptions, I think. I think I got a couple in the PSA. Very good to know the easy marks to get, to be honest. Okay, nice. Anyone put in some answers into the chat? Because there's quite a few possibilities. So shouldn't be too bad. Anyone give me a bag of fluid? Which one? There's quite a few possibilities. So very, very likely you're right. This is something that BNF would probably help you a little less than the other questions. This is something that's just good to know again. Okay. Over how long? Okay. Any other answers? Okay. Fine. Okay. I'm glad with these answers actually. They're very, very good to talk about. Okay, fine. So this is one that the BNF won't help you as much with. Okay. So the first thing to realize with these fluid questions is if it's asking for either maintenance fluids or resuscitation fluids. Okay. There's two different types. There's two different contexts where you'd probably give fluids. Okay. One's resuscitation and one is maintenance. Okay. Does anyone know the difference? What's either one of them? Resuscitation or maintenance? Because in the chat we've got some resuscitation indications and some maintenance indications. Yeah, good, great. So yeah, so resuscitation is mainly for your patients that are sick, they're hemodynamically unstable. So what that would kind of show is their fluid status and things like that is abnormal. So the main things you'd be looking for to do with, they're symptomatic, their BP is quite low. So that would be the main signs of hemodynamic instability. Okay, and their pulse could be raised as a result. So maintenance fluids is to do with when you're just trying to replace what they would usually have anyway. So this patient, there's a focus on that he's been eating and drinking less than usual. He can't swallow. He doesn't tolerate an NG tube insertion, so he can't take any oral fluids at all. So imagine you go a whole day without having any oral fluids. You're going to need some IV fluids, but it's not something that you would push a load of fluid in, over 10 minutes or 15 minutes because it's not an emergency indication. So we want maintenance fluids for this person, so it's a bit more slower fluids. But there's still points to gather in these questions. That's why they're great. So if you get, just the bag right or the amount right, you can still pick up some points. So some of these you'd still get, I think out of 10 marks, you'd still get some points, even if you push it over 10 minutes or something like that. So that's a benefit of these questions. So there's quite a few answers you could do. So most of the bags would be correct, as you can see. So in the bottom right, sodium chloride plus a bit of potassium, either that be 40 millimoles or 20. I'll talk about what this all means a bit more specifically in a second, but this is what the mark scheme shows. So sodium chloride plus a bit of potassium, either 40 millimoles or 20 millimoles, or you can just do sodium chloride. That's fine. Or you can do glucose 5% and again add some potassium as well. You could add some potassium because his potassium is 3.9, it's normal. You need some potassium in the day, usually. So it's good practice to give some potassium if it's normal and not on the higher end. Okay, and then not at risk of hyperkalemia. Okay. So also if you want to give maintenance fluids, the duration is important. So if you're giving, I think I have that on the next slide as well. But if you're giving 3 bags of 1 liters each, then usually you do them for 8 hours. So 8 hours, 8 hours, 8 hours to make up 24 hours. If you're doing 500 milliliter bags, then usually you do 4 hours. Okay. So that's a good duration just to be aware of here. Okay. So the way I think maintenance fluids comes up a lot more than resuscitation fluids. So resuscitation fluids is quite easy. You know what you need to push if someone's hemodynamically unstable. But maintenance fluids comes up a lot more. So So the way I like to remember it is, so the average person is 80, 80 kilograms. Okay. Now what that would mean is that there are certain rules. So usually an adult needs 30 milliliters per kg per day. Okay, so if you do 80 kg times by 30 milliliters, you get about 2,400 milliliters of water. So that's how much water you need in a day. Alongside that, another rule is that you need 1 millimole per kg of potassium, sodium, and chloride. Okay, so with an 80 kilogram male, you'd need 80 millimoles of potassium, 80 millimoles of sodium and chloride as well. And for everyone, usually you need 50 to 100 grams of glucose a day. Okay, so these are four things you need to consider. When someone's not taking any oral intake whatsoever, you need to think about this. Do they still need to get these four things to be okay? Okay. Now, when we come to prescribed maintenance fluids, then we need to hit all these four criteria. So you could do that in the form of this. Usually, this is what we usually go to. So I remember this as 2 sweet and 1 salty. So 2 sweet bags of 1 liter of 5% glucose and 1 salty bag. Okay, so that's firstly you would prescribe, your 1 liter of NaCl, then you'd have another bag of 1 liter glucose and then another bag of 1 liter of glucose over 8 hours each. So we've hit the water and the glucose fine, but we need to add some KCl as well, some potassium, because we need to hit these electrolytes as well. So what you could do is add 40 millimoles into one of the bags and 40 millimoles into another of the bags. Okay, it doesn't matter which two of the three bags you do, as long as they get 80 millimoles. Okay, um, fine. Okay, as I said here, if you're giving 3 liters, you'd usually do 8 hourly bags. If you're giving 2 liters, so if someone's very light and they only need about 2,000 milliliters of water, then you could do 12 hourly bags. Okay. A very important thing to know is that when you prescribe these bags, so you have 1 liter of NaCl and with 40 millimoles of KCl, you don't want to push that over. You don't want to push that in too quickly, 1 liter with 40 millimoles, because there's a rule of not pushing in more than 10 millimoles per hour of potassium. That's exceeding the maximum infusion rate. You would give them way too much potassium too quickly, and you can have lots of complications as a result of that to do with your heart and arrhythmias and things like that. So you shouldn't exceed 10 millimoles per hour. So the fastest you can give 40 millimoles of KCl is over 4 hours. Okay, that's important if someone is quite hypokalemic and you want to give IV potassium as fast as you can. If you want to give 40 millimoles, you can't give it faster than 4 hours. Okay, so that's something to know. That came up in my PSA. That exact question. It was a hypokalemic patient that needed IV fluids, and you can't give these things faster than 4 hours. Okay, fine. Hopefully that makes sense. I think fluids is because the BNF won't help you a lot, so it's something that you kind of need to know inside out a bit more. So hopefully that helps. So okay, some things. I'm assuming you give one bag of 8 hours and the second bag then the third. Does it matter which bag you give first? No, no, not particularly. Maybe if you look at the electrolytes or the glucose and you want to give some glucose first, or you want to, correct some potassium first, then fine. Um, yeah, could Lily get the feedback form?
Yeah,
Uh,
I'll just put that in the chat now.
cool. Um, yeah. You focus on first bag only for the question. It's asking for one bag, so it would be any of these ones. It'd be any of these ones. But what I wanted to just say is, you know, this is how you prescribe maintenance fluids for 24 hours. Okay. Um, for the PSA, it's only going to be one bag, but it's very important to know for the very soon future of you guys becoming F1s. So this is how you fully give someone IV fluids for a day. Yeah, hopefully that's it. I've outlined the children's one as well, but I think it's covered a lot more detail in the pediatrics talk because there's a specific formula. It's different for both maintenance and resuscitation, so I didn't fully go into it here. Okay. Oh yeah, another thing I didn't mention is it's 30 milliliters per kilogram per day for someone that a normal adult. But if there are some patients with renal impairment or they have heart failure or malnourished or they're at risk of refeeding syndrome, we tend to go with less fluid. Some of them already have, if they're renally impaired, they have problems with flushing fluid, cardiac failure, they've already accumulated a lot of fluid. So usually we tend to stick to, 20 or 25 milliliters per kg per day. But the PSA would be quite harsh if they gave you a patient that had heart failure or things like that. Like this one, it says that he does not have any evidence of cardiac failure, so you could just stick with the normal rules. Okay, fine. Another point is that when I was doing this is just like a very easy additional point to just know, but whenever the PSA asked for maintenance fluids for diabetics, it always seemed to gravitate towards this specific fluid. So I think I screenshotted this from a test that I got this question wrong. That's what I've read, but they like this specific fluid, so they tend to not like just the usual sodium chloride 0.9% because they want some glucose in there as well, along with some potassium. Okay, because usually during surgery, diabetic patients they have insulin running, that variable rate that we talked about, and that can cause hypokalemia. So at the same time, and obviously insulin can cause hypoglycemia. So a lot of the time they want a lot of things to be corrected at the same time. So this fluid in particular gives them the electrolytes in terms of sodium and chloride, but also glucose and potassium as as well as just giving them, their fluids. So I'd remember this fluid for diabetics. Okay, cool, fine. Getting to the end of the question, I think there's a couple more. Um, Fine. Hopefully that made sense. There's another question. So, what was the reason we give the KCl divided within separate bags rather than another bag that's given at a slower rate? Give the KCl divided within separate bags. So, okay, the bags either come in the way the bags just come is either with 40 millimoles or 20 millimoles. So if someone needs 80 millimoles, it would just make sense to put 40 millimoles in both if they're having 2 or 3 bags a day. I'm not sure if that answers your question. Um, Rather than another bag that's given that slower rate. Yeah, hopefully that answers your question. Um, Fine. Okay. Okay, 74-year-old woman has just returned to the ward 2 hours after undergoing elective lap chole. She reports severe postoperative pain. Okay, so looking at pain now. Um, Fine. Observations are stable. She has postoperative nausea and vomiting. She has CKD stage 3, history of a gastric ulcer. She has been prescribed in her PRN medication some oral paracetamol and some oral ibuprofen. What is the most appropriate and immediate analgesic prescription to give? It's already been prescribed, but which would you give? So this is on the BNF. Yeah, Lara's on it. Anyone else? What do you think? Okay. And if you put what page you think in specific helped you to get that, and maybe the people that are still looking and struggling. Okay, good. Perioperative analgesia. Okay, fine. It's getting to 8 now, so I'll go a bit quicker. But yeah, it's B. So give IV paracetamol. Oh, I've just realized it. I put I oral, but it is IV. Oh, sorry about that. Okay. It's give IV paracetamol 1 gram every 6 hours. The other ones, so especially ibuprofen and diclofenac. What's one reason why we could avoid that? Okay. Nice, nice, Paul. Yeah, yeah. So yeah, if that's a page, yeah. But also, so they have CKD stage 3. So you want to avoid things like NSAIDs, ibuprofen, things like that. So IV paracetamol is not good. So specifically perioperative analgesia, as your peers said in the chat. So there's a section called non-opioid analgesics, and it says oral paracetamol should be offered um, uh, before and after surgery, irrespective of pain severity, with intravenous paracetamol reserved for patients unable to take oral medication. Okay. Why is this patient unable to take oral medication? Great. Yeah, vomiting. Maybe should have bolded it. But she's vomited twice. Whenever someone's vomiting, or they're gonna vomit, maybe consider switching things to IV. Otherwise nothing will work. So yeah, so the oral ones are quite inappropriate. The NSAIDs are inappropriate. So yeah, we want to think about IV paracetamol, and paracetamol is the first line. Um, cool, fine. So obviously think about your WHO ladder. You must have seen this a bunch of times, um, but it's used a lot in practice. Actually, a lot of seniors just want you to refer to this as a protocol, so that you can have an excuse for prescribing crazy analgesics in the future. Um, cool. Fine. So some considerations as well. I think someone's not muted, so I'm hearing like an echo. I'm not too sure. Maybe not. I don't know. Um, yeah, okay. So some extra considerations for analgesia. One that comes up a lot, especially in that second section where you're trying to find inappropriate prescriptions and things like that. There's always going to be one that's cocodamol paracetamol. It happens a lot in practice as well. So it's really good to become comfortable with doing it. It requires a bit of calculation as well. So obviously the max paracetamol dose is 4 grams. So that's usually 8 tablets of 500 milligrams a day. Cocodamol can be 230/500 tablets. So 30/500 means that it contains 500 milligrams of paracetamol as well. So if you have that 6 hourly, you can already have your uh 4 gram dose of paracetamol. Okay. And also you need to consider with paracetamol, if a patient is under 50 kilograms, the max dose is only 2 grams. It's not 4 grams. Okay. This is something that like the pharmacists have to almost, pick up every day because it's so much. And paracetamol is so widely prescribed. So it's really good to get familiar with that inside and outside of the PSA. So yeah. And also side effects of NSAIDs. So again, I've used like the first letter of NSAID. So no urine for renal failure, systolic dysfunction for heart failure, asthma, indigestion, and dyscrasia, which is just problems with clotting. Okay, cool. Fine. Okay, one more prescribing, two more prescribing, but we'll fly through it. This one's straightforward. So, 65-year-old man is admitted for elective total knee replacement according to local protocol. He requires VT prophylaxis. What would you give? Again, as we said earlier, surgery is quite a big insult on the body. It causes clots. So we need to prescribe VT prophylaxis quite routinely. Mhm. Paul, so where did you get that specifically? Okay. Mm-hmm. Knowledge medicine's complete. Okay. Nice. Any other answers? So for VT prophylaxis for surgery, it's quite odd to start a DOAC for a patient. Okay. All right. Okay. Okay. Different answers. That's interesting. I'm not too sure what the mark scheme. There may be different. There may be different answers. Um, Fine. So where I specifically went, so I've got Dolteparin or heparin, and that's subcut 5,000 units, and it'd be stat 2 hours before the procedure. Okay, this is a 65-year-old man. His weight is 82. That's normal, and he's got normal renal function. Okay. Elective total knee replacement is just VTE prophylaxis. Okay, so I typed in venous thromboembolism or VTE, I think it comes up, and I went to surgical patients. Now I went to looked at this paragraph here, and it says pharmacological prophylaxis should be considered in patients undergoing general or orthopedic surgery when the risk of VTE outweighs the risk of bleeding. And you can scan. A low molecular weight heparin is suitable in all types of general and orthopedic surgery. Okay, so a low molecular weight heparin is probably your best bet. So dolteparin is a low molecular weight heparin. Heparin is preferred in patients with renal impairment, but I think it'll definitely grab some points here. Okay, so I clicked on dolteparin specifically, and what I get is 5,000 units for one dose to be taken 2 hours before surgery, and 5,000 units every 8 to 12 hours. But this is just one prescription, so one stat 5,000 units dose. Okay. Hopefully that makes sense. I know there's a range of. Yeah, okay, fine. Fine. Yeah, again, apixaban also it'd be started with specific indications as well. Um, if they need long-term VTE prophylaxis, not just in um, the perioperative space. So a knee replacement isn't something that we would want a Pixaban. We would start a Pixaban long term for a patient. You know, something like a valve replacement is something that we would want someone on a Pixaban for life for. Okay, 2,500 units. Again, you'd pick up majority of the points for something like that. So heparins we just mentioned. So heparins it says here on the so it says very, very short and quick. It says heparin is preferred in patients with renal impairment. A low molecular weight heparin is used for just general patients that are quite healthy, used for general and orthopedic surgery. Okay, so especially at my hospital, dolteparin and low molecular weight heparin, enoxaparin, things like that, they're used very widely. Okay, and heparin is for the renally impaired patients. Okay. Okay, cool. So 5,000 units dose is the standard dose for especially the weight that this patient's at and the renal function that this patient's at, because it mentioned that he is a normal weight and a normal renal function. So those are the two things you need to consider when you're prescribing a VTE prophylaxis. So again, just to quickly outline, so VTE risk, all patients that are immobile, which is nearly every patient, you know, post-op patients, obese patients, cancer patients, or they have a history of VTEs, they all need VTE prophylaxis. And that needs to be balanced with the risks of if a patient is actively bleeding, or their platelet count is very low, below 50, or they've had a recent major bleed, or they've got a procedure planned soon. Usually you actually stop these anticoagulants, the day before surgery, a lot of the time. So if you have big procedures going on, um, then a lot of the time the plan can be to stop them. So if the bleeding risk is very high, then you don't prescribe um, pharmacological VTE prophylaxis anyway. You would just give mechanical prophylaxis, which is through TED stockings. It's just a pair of very tight socks. So just things to have at the back of your mind. And as I said, so renal impairment, if EGFR is below 30, then usually you use a much lower dose of low molecular weight heparin. And very similarly, if you have a very low body weight, then you'd use a much lower dose. And if you have a very high body weight, then you'd use a much higher dose. This doesn't really come up in the PSA, just as a disclaimer. It's just something that you use a lot as a F1. You have to know this quite well. Um, this is a very bad copy of a picture, but this kind of shows that depending on the body weight, you have to adjust the dolteparin dose that you give. And depending on your creatinine clearance or your EGFR or your, general renal function, you need to adjust the dolteparin dose. So that when you prescribe that, it could be quite different. Again, this is something that a pharmacist has to chase every day. because sometimes prescriptions are a bit different. Okay. Last one, I promise, and then I'll let you guys go. This is quite straightforward. So this is a prescribing and antiemetic. So for a patient that has had a hernia repair and he's on postoperative morphine, patient-controlled analgesia, PSA, he gets nausea and vomiting 3 hours later after he's had the morphine. There's no antiemetic. Nurse wants you to prescribe some nausea and vomiting medication. So what do you think? So Netra, in the question, the patient didn't have renal impairment. He had a normal renal function. So it'd just be a normal 5,000 dose. If EGFR is below 30, off the top of my head, if EGFR is below 30, or they have a very low creatinine clearance, then the dolteparin dose halves to 2,500 units. But if they've got healthy kidneys, then just give them the full 5,000. Yeah, they should be quite simple. Antiemetics is not too bad. Again, I feel like there's quite a few possibilities that it could be. If anyone wants to just put in the chat what they think, so I think it is. Okay. Okay. Fine. Yeah, good. All antiemetics, so you guys are on the right track. So okay. So what I've gone for is cyclizine. Okay. IV. Why is it IV? Yeah, good. 50 milligrams, that's the standard dose, and TDS PRN, so whenever they kind of need it. Okay, fine. Now, I think I typed in nausea and vomiting, and it comes up with this page. This is a very good page to know about nausea and labyrinth disorders. That'll give you information on antiemetics. There's this very good paragraph here. It says drugs used include these ones. It says a sentence here specifically says cyclizine is licensed for the prevention and treatment of post-operative nausea and vomiting caused by opioids and GAs. Okay, so a good one to know in the context of surgery. A lot of patients are on morphine, and a lot of them will have nausea and vomiting from morphine. It's one of the most common side effects. So cyclizine is good knowledge to just have. That's the most effective one. It's likely that the other ones will also work um, to help them, but cyclizine has shown to be most effective. Okay, um, fine. And then I've put a table here that kind of just summarizes when best, what are the best indications for certain antiemetics and when to avoid, because there's definitely some ones that you do not want to give in certain contexts. So, when people have long QTs, you wanna not give things like ondansetron and haloperidol. If someone has Parkinson's, you definitely don't give prochlorperazine. Yeah. and metoclopramide as well. Okay. But as we said, so cyclosine's good for opioid-induced. Metoclopramide is good for, I just remember it to do with the gut causes. Prochlorperazine is to do with things that are up here, so vertigo, labyrinthitis, things to do with the ear. Um, yeah. Fine. Any other points? No, not really. Okay, that's a good table to just, yeah, you have my permission to just screen grab it. Cool. That's coming to the end of it now. I just wanted to copy and paste because I think a key thing about my whole thing has been, this test is testing your ability to use the BNF. So a lot of these things, again, feel free to just screenshot this, but I made a note while I was revising of all the key pages, um, all the key pages of the BNF that I wanted to just remember and get familiar with, and what useful information it contains. So some key things, anticoagulants, they come under like, weird names. Like some of these come under weird names, like benzos come under hypnotics and anxiolytics. And especially, I got some emergency contraception questions, and they're really annoying because you need to know the exact names of them. It's really hard to navigate BNF. You can't type in um, certain things, so it's good to know these names. What else? Yeah, overdose and poisoning. Um, yeah. So just have a look at this. Sometimes they do come up, so you can feel free to screenshot that and just use that in your revision. I literally made Anki, so Anki works really well for me. I literally made Anki cards of where do I find this, and I would just have the page of the BNF, like the title of the page, just there, and that helped me a lot with my PSA revision. So maybe that's a tip for you guys. So yeah, okay. Thank you guys for listening. Hopefully the slides would be shared and also a recording, I believe. So yeah, thank you guys for listening. If you have any questions, pop them in the chat. Hopefully that helped. It was very, very surgical focused. I wanted to just, give you all stuff that's just for surgery. So yeah, if you have any questions, let me know. No worries. Thank you guys for coming. I think you muted, actually.
Ah, sorry. Yeah, I
Right.
just said saying thank you. I'm just ending the recording now.
Sure.
Um,
Yeah.
here